Good morning, Master Ballecer. We have an interesting case today of a 78-year-old male status post-radical cystectomy who developed a large midline and prolapsed paraurostomy conduit. History is notable for multiple ER admits for small bowel obstruction, all treated with conservative measures.
Well, that sucks.
My resident and I, robotic retromuscular repair for a midline and paraurostomy hernia by Dr. Sakura Horiuchi and Master Ballecer.
Let's see the physical exam and the CT scan.
As you wish, Master. Patient complained of significant abdominal pain and ADL reduction because he was scared that activity would worsen his condition. CT scan is on monitor 3. Would you like me to call Master Paulie?
Sure, that's not a bad idea.
Good morning, Conrad. Looks like a large midline incisional hernia with a prolapse segment of his conduit. He also has a mediastinal mass, probably benign from valley fever and cholelithiasis. It appears that his lower midline hernia is the source of his bowel obstructions.
Thanks, dude. Lucinda, didn't we do one of these not too long ago? And despite listening to Yoda, still ran into some problems?
Unfortunately, Master, you are correct. All surgeons run into problems from time to time. Good news is he is doing very well right now. Just don't fuck this up.
Wow, thanks. How did prehab go?
Prehab went very well indeed. He lost nearly 30 pounds and walks 3 miles per day 4 to 5 times per week. He is ready for you and Dr. Horiuchi.
One of my problems last time was the inability to place a Foley catheter due to a prolapsed urostomy. I got urology to place a Foley under cystoscopic guidance. We gained intra-abdominal access and we saw significant omental adhesions and bowel adhesions. This is the area of concern that we saw on CT scan. He had multiple loops of small bowel stuck within hernias as evidenced by the CT scan. This was a very difficult part of the procedure, trying never to grasp bowel and pull, at least pull with too much force. It's all a matter of finding out where the adhesions are. I have bedside assist helping me with this portion of the case, trying to reduce these bowel segments. So we just took our time reducing all the bowel from these hernias within hernias, and I was pretty convinced that this was the source of his bowel obstructions. If I don't see a clear source of his bowel obstruction secondary to the hernia, a lot of times that makes me decide on an open procedure, because I think it's just difficult to do a full lysis of adhesions robotically, although not impossible. It seemed like whenever we would reduce bowel segment, we would find more bowel segments that were incarcerating within these hernias. Again, taking my time, doing meticulous dissection, trying to stay away from energy when I'm close to the bowel, obviously to reduce the risk of thermal burn. But ultimately, we were able to reduce all the bowel segments out of these hernias safely and without any evidence of bowel injury. Ultimately, we reduced all the bowel segments and performed a complete lysis of adhesions, which comprised approximately 2.5 hours long. I utilized an energy device to take down all the mental adhesions. Once the adhesions were clear, we had clear sight of the urostomy. We injected ICG down the conduit. You can see here, we can see the ureter at the terminal end, or the proximal end of the conduit. So this was after lysis of adhesions. You can see a small paraurostomy defect, but the conduit was prolapsing. It's nice that this was able to be reduced fairly easily, and it appeared to be where I concluded that it was straight at the end of this reduction, just by this look right here. So that brought us to the planned repair. My planned intervention was robotic bilateral tar, and given the length of the conduit, it seemed longer than normal conduits. My plan was to try to Sugarbaker and place retromuscular mesh in the form of a paraurostomal hernia repair. After incision of the posterior sheath, this is my suprapubic crossover, which provided access to space of retzius. This area was pretty scarred. Patient had a history not only of a cystectomy, but prior to that had a prostatectomy. Here is the subepigastric fat pad. It's important that this fat pad goes up, protects the epigastrics, and then you can dissect below the epigastrics on your way to the space of Bogros. There's the arcuate line. Previous to that, we'll do retromuscular dissection. I dissect posterior sheath to the closest aspect of the urostomy, and then we're going to make a slit in the posterior sheath that will eventually accommodate a lateralized segment of the conduit. So we're doing retromuscular dissection around the conduit. You can still see that the trophene is transrectus, and I'm dissecting to the EIT junction with retromuscular dissection and preservation of neurovascular bundles. You can tell here we're in the upper posterior sheath due to the thickness of the posterior sheath at this level, secondary to the interdigitating fibers of the TA and diaphragm inserting more medially. That creates this TA ridge, as you see labeled here. So we've completed retromuscular dissection. I've made a slit for the conduit. Probably have to make a longer slit, but my plan was to do a tar around this. You can see me using the head-in menu in the DV5. I'm trying to make this slit to the identified EIT junction and trying to dissect the posterior sheath off of the conduit in a 360-degree circumferential fashion. So I'm going to go to 30 down now, and below the arcuate line, we incise transversalis fascia to initiate bottoms up with exposure of the area of the space of Bogros. That's the preperitoneal space of Bogros. Get to the retroperitoneal fat, dissect underneath the arcuate line, digging a cave, separating the posterior elements from the lateral posterior sheath, and then starting my tar in a bottoms-up fashion that is caudal to the conduit. Care has to be taken to avoid torquing injury to the conduit, so I'm always looking back, making sure I'm not applying any force on the conduit. Now we start above the conduit, still going in a bottoms-up fashion, trying to dig this cave underneath the lateral posterior sheath. You can see I'm dividing the aponeurotic portion of the transversus abdominis muscle and dissecting that all the way down to the retroperitoneal fat. So we start going top down. Usually when I'm operating with my residents, we will perform all three ways to tar. This is somewhat analogous to bottoms up, except you're going from top down, but you're still separating the posterior elements of what you're preserving from the lateral posterior sheath, what you're going to be dividing, and that's typically muscular fibers of the TA, given that the TA inserts more medially on the posterior sheath. I always like to tell my residents the way you dissect is you envision that your fingers or your hands are in there, bluntly dissecting, and you try to recreate those movements with the end effectors. And you can tell that the left hand, right hand is always working in concert with each other. The camera's typically at the center of the screen at a fixed focal length. And that's what I train my residents to learn at first. And once they are able to do that, They can optimize retraction in order to be able to see planes. This was Dr. Sakura's first TAR, if I'm not mistaken. A very complex case, obviously. So I'm dividing TA here, and that kind of completes the transversus abdominis release. Now I'm just dissecting down to retroperitoneal fat. Here I'm doing retrodiaphragmatic dissection, trying to get adequate cephalad overlap. This patient had an incision that extended from M1 to M5, so that somewhat mandates a dissection towards central tendon and down to space of retzius. Notably, patient had a history of an incarcerated Morgagni hernia, had an open Morgagni repair. You can see that this is a permanent V-lock, so this area was kind of scarred. That's pars abdominalis that you can see there. But you can see after dissection, posterior sheath is obviously released, and I'm trying to figure out a way to lateralize this segment. ICG was helpful in being able to trace the course of the conduit. You can see it's a very long conduit. I'm not used to dealing with such long conduits, and normally I keyhole these. But given the length, I thought this would be amenable to a Sugarbaker or modified Sugarbaker approach. So I'm utilizing vicryl, and I'm lateralizing the second bent to the lateral abdominal wall. I don't take huge bites. I really only like to take mesentery here just to be able to position. Now I'm recreating the trephine of the posterior sheath. Take a bite of the mesentery of the conduit, and then closing this up to the midline.
How is your case going, Master Ballecer?
This shit's hard, Lucinda. Can we call up Yoda, get him in there, and make sure I'm not messing this up?
As you wish. Let's see if he's available.
Hello, Conrad. I'll close it real tight. So
We're utilizing zero barb suture, and as Yoda describes, you can close this up pretty tight. It's just passing urine. You just don't want to kink off the ureters. But again, given the conduit size, I thought we would be safe from that, and we had a good look at the proximal end of the conduit. Thanks for the popcorn. As you can see, I'm sized out the area, and I construct a slit around the mesh so as to not have any undue force of mesh on bow.
Put your mesh retromuscular. So I like to do extraperitoneal keyhole repair, and I'll usually double up the meshes. I'll put 2 meshes overlapping, so the slit in the mesh, because you have to slit it.
You can see that this mesh only covers approximately 3/4 of the abdominal cavity. My plan was to redock, place another overlapping mesh. I'm not sure that was the right call or not. But I really wanted to focus on the sizing of the mesh around the conduit first. So we placed trocars really in an oblique fashion in the right upper quadrant. That kind of makes doing a bilateral TAR difficult, but we start off with posterior sheath incision, some retromuscular dissection in lower abdomen, continued posterior sheath in the upper abdomen, making it symmetrical with the ipsilateral side. Do retromuscular dissection to the EIT junction. Preservation of the neurovascular bundles, as you can see here. And this is the anatomy of retromuscular dissection. You see the posterior sheath, you see EIT junction, the inferior epigastrix giving off the neurovascular bundles that point towards the head. That means that must be the left rectus muscle. So we enter into the space of Bogros again, doing bottoms up. That trocar was kind of in the way. I didn't want to completely release it. Continue on with dissection to the retroperitoneal fat. Excuse me, just a little hairball. But you can see I'm showing the V. Now I can divide the aponeurotic portion of the TA medial to neurovascular bundles and the EIT junction. go lateral, go cephalad, and then come back medial, utilizing that left hand as a static hook retractor. That takes me up to the upper abdomen where we do the Nowitzki, incision of the posterior lamella of internal oblique, division of the transversus abdominis to the transversalis fascia, and then do pre-transversalis dissection, again, all the way to retroperitoneal fat. Here's the area of the sentinel fat that underlies the costal diaphragm that you can see above me. And now, again, just continued pre-transversalis dissection here in this area. As you can see, even though this was Sakura's first TAR, and obviously a complex one at that, her movements started to improve within the course of the operation. The left hand is coordinated with the right hand. She was able to connect the retroperitoneal planes from the Nowitzki dissection and the bottoms-up dissection, leaving this at a little pedicle. Given that it was bloody, I utilized an energy device to transect the remaining transversus abdominis muscle. Then we attack the scar of the previous Morgagni repair. Doesn't look like there was a recurrence here, but dissect towards the level of the central tendon by following pars abdominalis that you can see here. So I thought we had enough cephalad overlap of the defect. I start, normally I close the posterior sheath first. I'm not sure why I closed the anterior sheath. That left the right upper quadrant trocar position wasn't great, and again, I didn't want to mess with the conduit. A lot of those movements working in the lower abdomen, I just didn't want to torque it and make a torque injury to the conduit. But we're closing the posterior sheath here. I start from cephalad, proceeding caudad in a modified canal-like fashion. We were able to close the posterior sheath, paying attention not to batter the conduit. Now I'm unscrolling the mesh that I previously put while doing a TAR on the other side. And I'm going to get another 30 by 40 centimeter sheet of, or 35 by 45 centimeter sheet of periotine, macroporous mesh, which will overlap the mesh. Now I'm finishing off with anterior sheath closure here, but in the very lower abdomen, I couldn't suture, so we redocked. And again, I didn't mind this because I wanted to get a good final look of the mesh relative to the conduit. We closed the lower portion of the hernia defect. We unscroll the mesh that overlaps widely the previously placed mesh. And I'm pretty happy with that look. We utilize Tacile for hemostasis and initial fixation. And then we place a 19 French JP drain. What's nice in the DV5 in the head menu, you can control the amount of desufflation. And then we just make sure it desufflates and the mesh doesn't fold.
You should be happy to know, Master, that your patient was discharged very happy on post-op day 3. You should also be pleased that Dr. Horiuchi performed admirably given her first TAR experience. I would recommend she go into her My Intuitive app, review her video and case insights to progress her to proficiency.